Should I have maintenance therapy for a fixed period of time or get it continuously until relapse?
So I think that the question has not yet been answered, but hopefully will be answered in the not too distant future. The two studies that showed an overall survival advantage to the use of lenalidomide maintenance therapy after transplant, they actually gave it until disease progression. One of the studies after transplant that did not see an overall survival advantage was the IFM study. And in that, while there was a clear improvement in progression-free survival, overall survival was not changed. So a lot of us believe that for now, lenalidomide should be used until disease progression as long as it's well tolerated. However, there's many of us who are very interested in seeing whether we can curtail that, and there's studies looking at, so there's a study that was done in France, the IFM determination trial, where they used lenalidomide for 1 year, and in the US counterpart to that study, we're using it until disease progression, so we'll have a comparison of 1 year of len maintenance versus continuous. Other study looking at 3 years versus indefinite therapy, and there's also studies that are looking at using MRD negativity as a basis for stopping lenalidomide maintenance therapy. So I think we'll have the answer soon. My hope is that we don't have to use it until disease progression, just for the sake of the patients. But for now, I would say until disease progression, as long as it's well tolerated.
So that's another great question that's, I think, still very controversial in the field without great randomized trials to guide us. If we look at the lenalidomide or Revlimid maintenance trials, in the United States, the trials gave continuous maintenance. In the large French trial, the lenalidomide maintenance was capped after 1 year. Both trials did show a benefit in terms of extending duration of remission. In the US trial, though, there was an overall survival advantage for patients who got lenalidomide maintenance, where this wasn't seen in the French trial. So this has led many US investigators to recommend continuous maintenance therapy, meaning you just stay on the lenalidomide maintenance as long as it's working, meaning until the myeloma comes back, unless significant toxicity develops. I think this is really still an unanswered question in the field, and we don't really know how long is long enough for maintenance. Fortunately, there are now some trials that are ongoing that are comparing 2 years of maintenance to indefinite maintenance with lenalidomide. Hopefully we'll get some information about that in the next year or so. In addition, there are recent trials that have started where we'll be serially doing bone marrow biopsies and looking for what's called minimal residual disease. Very low levels of myeloma that is below the level of our usual detection, but with more specialized tests can tell if patients may have even 1 in 100,000 or even 1 in a million cells may contain a myeloma cell. And the hope is that those trials will explore if you can stop the maintenance if you're minimal residual disease negative, or if you continue to be minimal residual disease positive, if you should change or add something to the maintenance. So we're hoping that these trials will give us a little bit more data to guide us and then allow us to guide patients about when you should stop or continue maintenance. At this point, I still think it's an individualized decision between each doctor and patient.